Natalia, thank you so much for joining me. I wanted to actually offer you an opportunity to do a more formal introduction of who you are, the area of specialization, and all the incredible work that you have done and continue to do.
It's my pleasure, and thank you very much for this invitation.
You're welcome. So can you tell us a little bit about who you are, because you're a psychologist. We're in beautiful Spain right now, and you have so much incredible knowledge and experience in eating disorders. And can you share a little bit about your experience, Natalia?
Well, my name is Natalia Seijo, and yes, I'm from here, from the northwest of Spain. You're with me now in this place.
Beautiful place.
And I have the background working with eating disorders and psychosomatics around 26 years now of experience as a psychotherapist.
Beautiful, beautiful. So let's start off by making the distinction between eating disorders and disordered eating, because there's a lot of confusion and people tend to blend the two together, and it creates some challenges and challenges for people to understand themselves, challenges for clinicians. So can you talk a little bit about the distinction between the two?
Yeah, this is a really good question, because nowadays I think people can be really confused about the differentiation between eating disorders and disordered eating.
Yes.
Eating disorders is psychopathology. Means that are all these eating disorders listed in the DSM, in the Manual for Psychopathology Disorders. And disordered eating is when the people regulate themselves through food.
Right.
And you can say, well, but also in eating disorders, people regulate themselves through food. Yes, it's true. Nevertheless, in the eating disorders as a psychopathology, you have more type of criteria of the diagnosis.
Right.
And the disordered eating is not a disorder itself.
Right. Right. So disordered eating is more around people turning to foods as a way of regulating their nervous system.
Exactly.
Connecting to their body or disconnecting from their body. Do you find it's more about disconnecting from their body or connecting to their body around disordered eating?
Disordered eating is when the person needs to regulate emotions through food.
Right, right.
If somebody, for example, break with a boyfriend or girlfriend, and then they need something to regulate themselves, and of course food is fantastic regulator, because, it's related with serotonin.
Right.
Or dopamine sometimes.
Yeah.
So the people use food as a regulator, but that doesn't mean that the person suffers an eating disorder. You understand?
Yeah.
Because you use food as I use sometimes, for example, alcohol sometimes,
right.
But not everybody that consumes a glass of wine is alcoholic, or 2 glasses of wine because they don't feel good that day.
Right.
It's just a regulator.
Right, right. So it's more like food, or disordered eating is more around nurturance and comfort and regulating the nervous system.
Exactly.
And eating disorders is more when you're hitting certain criteria that is within the DSM.
Exactly.
Yeah. And there's restricted and unrestricted ways of like disordered eating. Can you speak a little bit about that?
The disordered eating.
The eating disorder.
Yeah,
Keep asking. Talk about it.
No, but this is really good, because nowadays we can see in social media.
Right.
Everybody can talk about eating disorders, and when I see a lot of times that people are talking about disordered eating.
Right.
You understand?
Right. Yeah.
That is really important to say.
Yeah. And it's very important to say clinically as well, because I think that even as therapists, we go in with really good intentions and we think, we can treat eating disorders.
Yeah, exactly.
But we're actually, the knowledge or the experience that we have is more from the disordered eating realm.
Exactly.
And not eating disorders.
Exactly.
Yeah.
That is super important. Yeah, because eating disorders as a psychopathology, they're really important disorders and really severe sometimes. Right. And people die. In fact, eating disorders are one of the the ones with risk to mortality in the DSM.
Right. Yeah.
Right? Not just because the body is compromised as well. It's also because the risk of mortality related with suicide. So that is really important to remember, because not everybody can treat people that suffer eating disorders.
Right.
Just specialized that professionals specialize in this type of disorders should treat eating disorders. Disorder eating is not less important. That's important as well.
Right.
But it's the people that treat eating disorders, professionals treat eating disordered eating, that can be more general psychologists, not just a specialized one.
Right. Right. It's kind of there's more high risk to eating disorder cases than there is to disorganized eating.
Yeah. Because disordered eatings can be people. Sometimes they have. Like I said, just around attachment or just daily life problems that can be related with that. But eating disorders is related with trauma.
Yeah, so I'm so glad that you mentioned that, because it often gets missed. The trauma component of eating disorders really is oftentimes neglected within mainstream mental health settings.
Exactly.
So can you talk a little bit about the trauma component and how it's connected to eating disorders, and perhaps attachment as well, and violations of attachment? Can you address both? Because it often gets missed, and it's so crucial for the healing of eating disorders.
I'm going to start saying that the classical treatment for eating disorders is just treat behavior with food. Right? This is the classical type of treatment.
Yeah.
And over the years, I also teach, as you know, and when I go to conference or meetings, in fact, I'm thinking about the last one with families. That was a meeting with families. This is not practical talking. I think it's better explained in this way.
Yeah.
And I was with all these families there. And of course, in front of families, I cannot talk about certain things because I don't want to hurt families. Because
you don't want them to feel like they're to blame for.
Exactly.
Yeah.
So I was taking care of my talking here and there. But in some moment, I started talking about trauma.
Right.
Those families were treating the family and the patients with the classical treatment and treatment for just focus on behavior.
Yeah.
So I opened the door and I said, you know what? Let me tell you something, because I work with eating disorders beyond behavior with food.
Right.
For me, behavior is just the peak of the iceberg, but you can see the level of sea, but underneath the sea, as a metaphor using the peak of the behavior with food, there is the root,
right? The pain
and the pain and everything else. Yeah. So I opened the door in front of the families and I said, you know what? And trauma is the root of eating disorders. Trauma can be attachment trauma, and don't get me wrong.
Yeah.
And you do beautifully with your daughters and sons. It's nothing about that.
Right.
It's not guilt. I'm not going to look for guilt. It's just explain clearly what happened here. Yeah. So I start talking, and I talk about the attachment that can affect eating disorders. I was talking about the grief in families, and grief is one capital T trauma affects families, and sometimes with the grief is there, and it's a complex grief. People don't realize it can be also the root for eating disorders.
Yeah.
And then also, of course, abuses, emotional abuse, power abuse, from the narcissistic figure attachment. Sometimes you have sexual abuse, and that is huge in eating disorders.
Absolutely.
And all of this, and the families after that, were like a super serious faces. And when we finished the meeting, 2 mothers came to me crying, and they said, why nobody told me this before?
Okay.
My daughter is now 30 years old. And my daughter started with this when she was 14.
Yeah.
My other daughter died. And everybody told me that is not an eating disorder, the root for the eating disorder.
So this mother was told that her daughter's death was not related to her eating disorder?
The professionals told her that.
Oh my gosh.
And then I opened the door when I say, the apathy and the grief, and the mother was like, talking about this. Why nobody told me this before? Why not, Natalia? Crying, my heart was broken in that moment. Oh my God, I'm so sorry.
But you offered an important perspective and understanding. Because when you talk about eating disorders, it's just behavioral based.
Exactly.
You really don't you think, well, then something's wrong with my child or something's wrong with me. But there is like, no, it's not that something's wrong with you, it's that something has happened to you.
Exactly.
And it's deeply embedded in your body.
Exactly.
And you haven't found a way to work through it, and your body is trying to regulate when you feel unsafe. And it's so,
it's like it doesn't talk about you guys.
Right.
It talks about the environment, the things happen in life that you can solve. But, and I see now with my young clients or patients, when they come to my office with the families, and I say, we cannot wait. Because when the seed of eating disorder is inside of the system,
of the family system. Yes.
The family system and the system inside.
Yeah.
Because, I talk about the inner world of eating disorders.
Yeah.
And they create like a type of, structure inside in the eating disorder. Or you take quickly the treatment and you take quickly this system to, combat again inside. Or the system start creating the structure of the eating disorder inside of the person.
Right. I love how you're addressing both of this, because you're absolutely right. It's that familial system that needs to be addressed, which is external to the person.
Exactly.
But then there's an internal experience that someone has.
Exactly.
And can you say more about the internal system? Because I think with the classic-based interventions of CBT, DBT, the internal system gets completely neglected and ignored. And then the person ends up feeling like they end up feeling like they're horrible in some way. They just don't have enough willpower. If only they had willpower. Talk more about the internal system, because I think that's so crucial.
Yeah, it's crucial because from those treatments, the person feels, as you said, I am not good enough to heal my eating disorder. I don't have power to or motivation enough. It's nothing about that. Of course, you help yourself if you do that.
Yeah.
But what happened with the person cannot? These chronic cases.
Yeah.
Chronic cases. It's like this mother with this daughter. Chronic. Over the years, you know what? Your daughter could be fixed before the system. If somebody could go beyond the behavior with food. You know why? Because inside, I always talk about I use the metaphor like an artichoke. Yes. It's like the artichoke metaphor, it's like you have the bloom child inside, and this is the heart of the artichoke. And around that, you create, the system create layers and layers of protections.
Right.
These layers and layers, that is the eating disorder, because eating disorder is based on defenses. Layers and layers and layers of artichoke. And then we have to, little by little, not delete it.
Right.
No, they smoothly try to help the system to let it in. And then you find the
wounded
child.
And
here is the inner world. And the inner world, I put names of that in order to talk, to speak the same language of my clients.
Right, yeah.
And I talk about the little child who never was, the little child who never grew up, the rejected self, talking about the distortion in the body for some type of eating disorders. We talk about the fraud self, that inside, with all these protections, they feel like imposters sometimes.
Right.
The piranha is like the critic. Then the critic is not a bad thing, it's a good thing, but the good thing later on in life became not good at all.
Right.
By the beginning, protecting themselves inside as well.
But let's slow this down a little bit, because what you just shared, there's so much there, and I think it's important to highlight it, because in the middle, you're saying, is that wounded child.
Exactly.
It's the child that wasn't seen, wasn't heard, didn't feel safe enough, or loved, or was potentially violated. And then there's the layers of the artichoke, which are the defenses, ways of protecting and sustaining themselves within the woundedness and the wounded environment, wounded self. And so you slowly treat the eating disorder, because we're focused here on eating disorder. So we slowly treat that so that we can get to that younger wounded self.
Exactly.
Okay. And what modalities do you normally use in treating the eating disorder defenses and then the younger child self?
Yeah. Well, I'm a trainer in EMDR.
Yeah.
And so I use the 8 phases in EMDR to treat eating disorders. That is what I use. And of course, the first phase is like a history taking, and there I can conceptualize everything that we explained from the very beginning. Yeah. And then I design a treatment plan. And this phase 2 is where I do all of this. I work with defenses smoothly, I recognize what type of defenses we have there. I provide with pieces of psychoeducation in order that the cognitive level the person can understand what's here and there. And of course, before all of this, I just regulate the symptoms with food, because when I talk about beyond food, people think that I don't touch the symptoms with food. And of course I touch if not, it's very difficult to go, with the next levels. Mm-hmm. We cannot treat defenses if we don't regulate food first. That is the base thing. But also we have to treat the symptoms respecting the restriction and respecting the overeating. Right. That is the first step. This is treatment.
Right. Yeah. And the language that you use, some people are going to think that you often lean on internal family systems or ego state. What's your preference? Do you tend to use ego state therapy in terms of working with different parts and different aspects? What do you mean?
Because people ask me this a lot. Yeah. Because this inner world in eating disorders I designed all of these right before
internal family systems
was very famous, And now people say, "Oh, you're working with..." No, because ego system, the ego state system and approaches was there before what? 2000, 1999.
Right, exactly. Ego state. What? Oh my gosh.
I don't remember.
I think it was 1950s, 1960s. Watkins and Watkins.
Exactly.
When you've been in the field for more than 20 years, you kind of lean more towards the ego state or ego.
Yeah, exactly.
Than IFS.
So that is one of my first work. I was there working at the beginning. Were not of them, just 2 or 3 that I saw from the very beginning of my clients. Even when I was in a hospital, studying to be specialized in eating disorders, and I saw that. And in fact, the inner critic, that called piranha, was one of my clients. From the very beginning, it's like a piranha inside, like a biting me in the brain. So that is why I call this
The critic, the piranha.
I was really young psychotherapist at that moment.
And this is the thing, is that our clients teach us, right? And so from very early on, when you first went into this area and this field, you listened to your clients. There was like these common patterns that you noticed, but then you used language that came from clients, and that fits and makes complete sense. And so so talk a little bit more about the common states that are present. So the common defenses and the common states that are present with restricted eating and then and overeating. Because you just mentioned the piranha, the critic, is a common state that's present for folks. Can you say more? Does that exist with both restricted eating and overeating? And what are some other ones that are present?
Well, for example, in anorexia, and that is why I learned all of this because of my clients. No, this is not my design because I wanted to put the pics in my clients. It's not my clients taught me that, as you said.
Yeah.
So one of the common ones is the little child. That who never was. And that is the anorexia nervosa type.
So say more about, if I know what you mean, but for some folks, I don't get it. So say more about the little child that never was.
Yeah.
Is it the child that was never allowed to have a voice, that was never allowed to be seen? Say more about that, because that is such a powerful statement.
Yeah.
And there's so much that's there related to the child that never was.
Yeah. So that state is like the main representative one in restrictive disorders, like anorexia nervosa, restrictive type, or purgative type. And so in this type of disorders, this state is regulated by control.
Right.
Control is the protection, can be the defense, because it's a protection, really.
Yeah.
So the control, the person learned to grow up through control.
Right.
Because, of course, the background was over-controlling, or the background was totally under control. Right? Is correct.
So like an experience. So if I am understanding correctly, when there is a situation where there is anorexia, there is the child that never was, and they often experienced a lot of criticism. They were controlled a lot in early childhood, whereas they were or throughout their years, there was a lot of control placed on them,
or the opposite.
So
they need to take a lot of control in order to control themselves, because the environment was over-controlling and they cannot control anything.
Okay.
So, of course, they develop this over-control, or the opposite. The environment was not, the control there was not at all. So the kid also needs to control something.
Right, they need to be able to manage because there was nothing available to them that they ended up having to manage the neglect, like their kind of experience. Okay.
So the control is over food. Right? And in this type of environment as well, you can see with the people with this state, with the child who never was, is that the parenting. I mean, the child is reverse.
Right. So they become parentified by going into a controlled state.
Exactly. So it's at the same time, it's a state with a lot of power.
Right.
Because the kid became a really powerful figure attachment for their own parents. And then it's difficult when for example, I have several girls in my office that when we say to the family, you have to serve food to her, because I think it's important, because she is not able. And the girl is very quiet looking at me, and I know inside is the little girl who never was saying, "Are you serious?"
Right.
She is late for that.
Right.
this lady was serving me in the plate. Now, me with 15, she was not there before. I was always the mother here. So what are you talking about? She does say anything, but through her eyes, I know that, and it's like, yeah, of course, how.
And then this is where it's really important to work with the implicit, the what you can sense in her eyes, and to use curiosity to really look at what's happening here with those eyes that are looking at you and those eyes that are saying, now you want my parent to show up? Now you're asking, as a professional, now you're asking my mom or my dad or my caregiver to show up. It's late.
It's late.
Yeah, but that you're bringing up something really important around the how we need to be curious about what's implicit, what's there in the office, and that look. I love that because you're absolutely right. If we take that traditional approach of behavioral and it's just all about behavior,
that means all of
we miss the attachment injuries, the trauma, and that little girl or that little boy inside, and the injuries and the woundedness. It gets all messed.
Exactly.
Yeah. So I wanted to talk a little bit about the overeating side of eating disorders.
Yeah.
Talk a little bit about the wounded child within when it comes to overeating.
So when the restrictions one where the kid who never was, in these ones is the kid who never grew up.
More about it.
Yeah, this is really good.
Yeah.
Because of course in the restrictive types you also have this other group that never grew up, and the kid who never was is really phobic to the other one. Because the one who never grew up is the one never received their needs. Their needs never were met.
So is it the kid that never grew up is is a person who in childhood never really was taken seriously or was loved or love wasn't overtly shown.
Exactly.
Like I'm just thinking of a client in particular, and I'm thinking of how love wasn't expressed within the home that she grew up in. And so there was always this constant need to get approval or to get some kind of validation. And when that wasn't present, the overeating, she would turn to food and she would overeat. Is that what you mean by the person that never grew up? Is that the attachment need of love wasn't overtly shown? Is that some of the attachment needs that weren't met?
Yeah, it's like in this home, I always use this like belief, phrase, like in this home is needed to be sick in order to be seen. That's correct. Like, do you understand that?
Yes. Yeah. Okay.
Yeah, it's like for example, you can see this in people that suffer from eating disorders, overeating disorders.
Yeah.
And then overeating disorders, we know this is like binge eating disorder, hyperphagia, nocturnal eaters.
Yeah.
You know, this type of people suffer this type of disorders. I want to say this correctly. That when they need to eat a lot to cover something inside to just feel better, right? You know, through food.
Right.
And then the most of the time, they feel that sometimes they eat like a kid. One of my clients said, you know what, you're right. Because one day I asked her, but you sometimes eat like a little girl. Did you see that? So long. In fact, in the restaurants, you know what? I always ask for the menu for kids. Don't take me never to Michelin star or this type of restaurants because that is not food for me. It's like I eat like a little girl inside. And then I describe for her the little girl who never grew up, and she says, yeah, I covered and meet the lack of love with that, my emotions are covered, my anxiety sometimes when I feel alone and covered, all of that, those are the needs.
Right, right. So fascinating. I keep on thinking about how we so need to do the work in this way. Otherwise, it gets completely messed. Because if you don't ask questions like, when you're eating, what age do you feel like you are? What do you feel like food is offering you in those moments? How is food taking care of you? If those questions don't get asked, so much gets missed, and then that's where you see sort of the revolving door of people going in and out of the hospital or residential-based eating disorder places. It's just sort of like a revolving door.
You are outside, making rounds around the artichoke.
That's right.
The whole time, you never go in. You're just around the artichoke the whole time.
You're kind of at the top of the artichoke.
Really.
And you're
that is why some people became chronic. Because nobody go in and fix that.
Right. Talk about pacing, because you're saying something really important in terms of you got to deal with all the layers of the artichoke. You got to go to the heart of the artichoke. Pacing is so important.
Oh yeah.
Because if we don't pace correctly, then I would imagine the artichoke go like, well, tighten up, and then that sometimes will be like, oh, you're, so say a little bit about pacing, because that's so crucial.
It's crucial, and you have to be just at the same rhythm and symphony, but as the inner system. That is why it's important to regulate food and then go to the little by little as the system let us go, because it's not always when we want, it's when the system, needs to be, will be available for us to go in. So we have to just work with regulation with food and then little by little go there, and then sometimes, we have to go backwards a little bit and go again. So that is very important.
Yeah.
That is very important.
And you mentioned the 8 phases of EMDR.
Yeah.
You are a trainer in EMDR.
Yeah.
And the beautiful thing about the 8 phases is that we go in it. Like, we can be in phase 5 and go back to phase. Like, we could go in and
it's like a dance.
It's a dance.
It's like a
dance. Absolutely. And when you say we have to regulate food, are you speaking about regulating food with the different layers of the artichoke, with the different defenses?
Oh, yeah.
Okay. Say more about what you mean by regulating food with those different layers and with the defenses, because I think that's an important piece.
Yeah, because, for example, in bulimia and binge eating disorder, we have something very important to talk about. It's like urge.
Yeah.
People have this urge, the urgency to go and eat very quickly, because that is one of the main characteristics of the binging.
Yeah.
It's like an urge.
Yeah.
So people cannot control food because people feel this impulse inside, and then when the impulse appears, then most of the time we have to start talking about dissociation here.
Okay.
Yeah. And this is the third column, because I talk about eating disorders, the 3 columns.
Yeah.
Attachment, trauma, and dissociation.
Yeah.
That is why I talked previously. That no everybody can treat these disorders.
Right.
You have to be super specialist in this.
Right. You have to have knowledge of attachment, trauma, and dissociation. And say more about how urges are connected to dissociation.
Exactly.
Yeah.
So when the urge is this impulse, right? Impulse to go in it. So when this happens, the person goes and start eating very quickly. That is one of the characteristics of the urge. And in that process of the binging, the person normally doesn't remember what type of food or amount of food the people ate. So when you ask, so tell me please, many food you put in your
Yeah.
plate, or
Yeah. What food did you eat? The quantity.
exactly the quantity. The person says, "I don't remember."
Right.
Because in that moment, it's like this type of dissociation.
Yeah.
That sometimes important authors like Anna Hughes, for example, was related, was associate that piece with freezing response. That imagine how important it is to know all of this. Because the person doesn't remember the quantity of food, the person doesn't remember anything. Just the person remember, oh my God, and my stomach is super full after this. So if you treat urge, you can also help the person to calm down the system, and they can control better this impulse. So that is regulation with food.
Right. And just thinking about all of this as you're talking, because it's so important that, you know, just hearing that urge, there's an urgency to, and there's like, and there's a lot going on internally for that person, and they need, that food is offering them something, but there is almost like an overwhelm in the experience that they disconnect from themselves, or they dissociate from themselves.
Exactly. And here is what because I differentiate between somatic dissociation and somatoform type of dissociation. Somatoform is, of course, you know, the symptoms as symptoms in the body, like a disease symptoms. But here we focus on somatic dissociation, when you don't feel the body as yours. And that is what happens when the person suffers eating disorders. And most of the time, it's a level of type of dissociation, like a disconnection, detached. Dissociation over there.
And from, I'm kind of hesitant, but I'm going to ask this: if this gets missed, what happens for people? Like in terms of like, if clinicians, if therapists, psychotherapists, if they missed the dissociation piece, what happens for folks when dissociation gets missed?
Well, these chronic type of levels are coming the whole time.
Relapse.
Yeah, exactly, because you just work with one part of the system, is the cognitive level, but the rest is in the body. The body suffers really a lot, because when the person doesn't feel the body as on, you know, what happens is that the person doesn't care about the body at all. So, for example, in anorexia, they are totally detached. And this is we have to complete again and put together these two big pieces. But the body is the big part is dissociated. That is why the person, the most of the time, when I say you have to eat, and if not, something is going to happen with your body, it's like, oh, come on, and it doesn't matter to me. Because they don't feel the body as on. In fact, they reject the body. That is why
I was actually thinking of that language as you were talking, is that there is a complete rejection of body.
Absolutely.
And there is a disconnection. It's like, the body is here, but it's not really mine.
Exactly.
And I don't feel it, and I'm not connected to it.
That is why I talk about the rejected self.
The
rejected self, is based on that. The whole thing about the somatic dissociation, in fact, is the other can be ego states. This one is normally a dissociative part. And this is not treated most of the times. For example, with this distortion in the mirror, and they don't see their own reflection. They see the reflection from the past and all of this. That is the somatic dissociation, and most of the time they don't feel the body as on, and then the distortion tends to psychoform type of dissociation.
Do you find that you've mentioned 3 pillars, and in the 3 pillars, do they normally exist for all eating disordered cases? Is it normally that there's attachment wounding, there's trauma, and there is dissociation?
It's different levels of dissociation, because somebody can have dissociation or not, in other type of disorders or when complex trauma, or, you know. But there is also a percentage of dissociation, because dissociation at itself is a make distance, you know, for everything is painful for me. So in the body is a big produce of pain. You know, the pain maker. You know, I put my body detached from myself. In fact, for example, in victims or sexual abuse, and eating disorders, you have an interesting percentage of this type of victims. You know, the body, you know, takes the whole trauma. Right. And they cover by layers of fat, you know, trying to cover themselves, or just delete the fat, and they want to be like a little girl to protect themselves, and that is the.
Do you find when there is sexual abuse, do people often go into the overeating, or do they often go into the restricting? Like, what's the differentiator between someone, like, what am I trying to ask here? Because I've had cases where with sexual abuse, they go into restricted eating, and in other cases with sexual abuse, they go into overeating. And I haven't quite figured out why. And so I'm curious. Do you have a sense of the why some people will go towards the overeating and some people will go into the restrictive when there has been sexual abuse?
You know, here we also need to talk about the profile of the personality.
Right.
Because it's another important factor here to talk about. Because why some people, you know, develop restrictive disorders and other ones, you know, is because your profile of personality, your temper, and your character is important also. Because and also the attachment. That is why when you conceptualize eating disorders like this, you can, you know, put the list of characteristics and factors and okay, this is restrictive disorder. So I think it's that one.
Right. It's the attachment piece and then also the personality piece.
Exactly. Because the person has this profile of personality. So some people can control a lot because they are this, you know, by nature. And other people cannot control anything because their nature is like, oh, come on, I cannot. And this is the truth, you know, because we also have genes.
Right. You mentioned earlier the pillars, and I love how you present the pillars and understanding the wounded part within, the younger part within. Talk a little bit about, because it's overwhelming for family to know what to do without going into trying to replicate the kind of environment that created the eating disorder to begin with. So oftentimes family will like sort of double down on control, or they'll go into a fear-based perspective and they get overwhelmed and then they distance themselves. What can families do when they understand the pillars that are in place? Because I think that's the most important piece. It's in the beginning of the conversation you talked about how families really need to have a sense of trauma opens the door to this. Attachment wounds open the door to this. There's a dissociation that needs to be considered and worked with. All of that, families and support people need to understand this. What else do they need to be able to support someone who's healing through an eating disorder?
I think families need to understand, you know, they need to understand all of this. Because when they have, you know, information is a value thing to have. Because when you have information, you can treat, you can talk, you can wait, you can act. But if you don't have all of this information, you just feel like absolutely lost. And then, of course, you feel angry and frustrated, and you don't want to continue with this. And So when families, first thing is like when the families have information, that is important.
Yeah.
The second thing is, and I since the very beginning in my specialty as an eating disorder professional, I always believe that you have to teach families and I don't know how to say that.
In Spanish, and I might be able to.
Maybe, yeah, you can
be able to translate.
It's like you need to liberate families from the guilt.
Oh, yeah.
That is the first step.
Yeah.
And sometimes some of my colleagues say, but families sometimes are getting no.
Yeah.
You don't want to work with families full of guilt because they normally, even if the families are not okay, they normally, unless that psychopathics or people with severe, disorders, families normally, want to treat kids with love, but maybe sometimes they cannot.
But they have their own wounds and they have their own history of attachment.
Exactly.
You're absolutely right. And I love that you have to liberate families from guilt.
I have one of these pictures in my slides when I teach.
Yeah.
And it's like the father, you see the father like
hidden down.
Oh, no, hidden. Yeah. The kid was the little bad here. And the father, you see the action there. But the father's son is facing back, and his back is full of hands. Like
the father's back is full of hands as he's hitting his son.
And I like
that's a powerful image.
Powerful image. And with that, I normally describe that of course families, they take their own burden.
Yeah.
We understand that, and we also treat our clients, of course, because the families have their own issues affect our clients. But if you liberate families from guilt, it's easier to work with them because if not guilt, it's like generate a lot of protections, and then you cannot go because the fences are there also artichokes from the family.
Right, absolutely. And what you're talking about is beautiful in terms of there has to be this parallel process of the person who's suffering with an eating disorder needs to be healed, but their family also needs to be healed.
Absolutely.
Yeah. On that note, to close off, if you can change the way we talk about eating disorders, clinically and culturally, what would you change and why?
Well, I would like to change the judgmental talking about eating disorders. And because these people, when they come to my office, for example, people with anorexia, and I remember this because we talk from our clients.
Yeah.
And this person told me, Natalia, let me tell you something, because maybe you don't understand this. But when you are labeled by anorectic person, that is very, very unrespectful, not suffer anorexia nervosa, no, anorectic person, everything you say is a lie. And that for me was like, I'm so sorry about it.
Wow. So this is a client that says, I don't want, when I'm labeled as anorexic and you talk to me as an anorexic, then everything is because the diagnosis was anorexia nervosa, and people call her, you are an anorexic person. And she said to me, everything I say in every place is a lie. Right, it gets clouded by that label.
Liar. I am a liar. If my belly feels bad, of course your belly feels bad because you don't want to eat. No, it's because my belly feels bad. Wow. Everything. So I would like to change that.
Yeah.
They're not liars. They have a problem.
Yeah.
They're not histrionic. They have a problem.
Yeah. Yeah.
They don't. They are not a people just want to eat because they want to be like this. No, it's people they have a problem. So not judgmental. I believe that judgmental thinking about is
it reminds me of how when we take a very behavioral approach, people feel like they can't trust themselves anymore.
Exactly.
Because they're told, no, your thoughts are wrong. You have to challenge your thoughts. You have to challenge what your body's experiencing. And here's a prime example of a client saying, I've been told I'm a liar because I have this label and I'm tired of this. Do you want to change? That's a beautiful wish.
I don't want to put the guilt in our clients. I want to take this guilt out and then open the door in the window from the inner world in eating disorders.
Beautiful. I have chills just as you say that. Thank you so much, Natalia. So appreciate all your work, your beautiful words of wisdom, and I'm just really grateful. Thank you.
Thank you very much.
Thank you.
My pleasure.